have found their time from their busy schedule to arrange this masterclass. And special sincere thanks to Professor Amita Agarwal, who will be delivering lecture today in our masterclass for our PGTs as DMD as well as MD PGT as well as for us too. So today this class will be chaired by another very renowned internist and rheumatologist, that is none other than Professor S.B. Ganguly, who is ex-retired professor of the Department of General Medicine as well as Rheumatology Unit in Medical College, Kolkata. And at present, he is emeritus professor attached to one of the most important corporate house, that is Apollo Clinicals, Kolkata. So, with this short introduction of our chairperson, I over to Professor S.B. Ganguly to introduce and start the proceeding and to introduce our speaker, madam. Over to Professor S.B. Ganguly, sir.
Thank you, Professor Kormukar. Introducing Professor Amita Agarwal to the doctors is just introducing Mary Curie to the gang of physicians, or Audrey Hepburn to the film journalist. She is so famous. She passed her MBBS from All India Institute of Delhi. Before this, if my memory serves me correct, she passed some years of his life in Tripura. So, ektu Bangla jane. Then he shifted for DM in SGPGI and passed DM from there. Innumerable medals, honor in her life. I don't know how many papers she has presented in different international journals. It must be four-figure. And we are always moved, touched, and learn many things from her speech. So without wasting any time, I request Professor Amita to start the proceedings.
Thank you, Dr. Ganguly, Dr. Partha, Dr. Sarkar. I mean, I don't deserve any of these. I am still a learner, and I think every physician learns every day. And you are taught in the every time you see a patient who comes to you for follow-up that how wrong you were. So the most important thing in medicine is to have humility to accept your mistakes. And that what keeps us going and learning. So what I'm going to present is some of the cases where we also learned over time, even though we might think that we have spent 40 years in this profession and we should be knowing everything, but we don't know. So I'll start with simple cases and then go to some little bit more complex for you. You can stop me anywhere. I mean, this is basically for students. So it is absolutely based on the cases which we have seen. So I don't have any financial disclosure. All my life I've worked for the government. So I mean, SLE, as the students know, nowadays the students know more about SLE than about simple diseases because that is what is asked in the MCQs. So we are a MCQ bred generation. It's basically a prototype systemic autoimmune disease. Autoimmune diseases are becoming more prevalent in our country with the control of infections. And it's a disease which can have all kinds of clinical manifestation. So as what was used to be told about syphilis, that it can mimic any disease, in today's world, lupus can mimic any disease, starting from head to toe. But the most characteristic feature about lupus is that since it's an autoimmune disease, you have multiple autoantibodies in this disease. And nobody knows what is the cause. But it occurs more often in women. There is some amount of genetic susceptibility. So if you see 100 women, maybe two of them will have a family history of lupus in their families. And it's also a disease where there are ups and downs. So it generally never goes away ever in your life, but you may have periods of remission which may last for years together, and you might think that the disease has gone, but it can still come back. So that is why it's a most unpredictable disease which can present with any clinical manifestation. Thus, you need to have your eyes and ears open to a possibility of lupus in a patient in a proper clinical setting. So let's see the first case. She's an 18-year-old girl who had low-grade fever, malar rash, oral ulcers for 2 months. She also had fatigue. She had no alopecia, no arthritis. And when we examined her, we found she had pedal edema, she had mild hypertension, and you see her rash. Making a diagnosis is not difficult in such a case. Even an undergraduate will make a diagnosis that you have a classical malar rash, you have nasal ulcers, you have oral ulcers, and she has all the features. So this is a multi-system disease. So it tells you that there is skin involvement, there is kidney involvement, and there is systemic features. But you don't get any prize if you make a diagnosis of lupus in such a patient. This everybody should make it. In contrast, you see this lady. She's a 24-year-old lady who came to us with symmetrically inflammatory polyarthritis for the last 6 months. She had involvement of small joints. You can see spindling of fingers. She has wrist joint involvement. And she was rheumatoid factor positive. Her X-ray had been done outside, which showed soft tissue swelling. Thus, the general practitioner referred her as a case of rheumatoid arthritis. Very rightly, because she has all the characteristic features to make a diagnosis of rheumatoid arthritis. But what that person missed, when we asked her history, she had a history of photosensitivity. She's been having off and on oral ulcers, which she never thought was related to her arthritis. She had mild anemia. She had normal counts. Her platelet count was only 1.5 lakhs, but her ESR was 100 and the CRP was perfectly normal. So when you have this discordance in a patient who has inflammatory polyarthritis, that the ESR is very high but the CRP is not high, think of lupus. The second thing is whenever you have inflammation, generally you get thrombocytosis. So this patient, even though has normal platelet count, it is not in commensuration with her inflammation, which is reflected by a ESR of 100. So these are subtle points which would make you think that am I dealing with some other disease? Her liver function and renal function were normal and so were her urine exam. So this patient actually on evaluation further turned out to have lupus. She had ANA positivity, high anti-dsDNA, low complement levels. So in a patient who has polyarthritis, look for these signs. And joint manifestations are very common in lupus, but most of them will generally have joint pains. They are frank arthritis is seen only in about 20 to 25%. And this arthritis is usually non-erosive, in contrast to rheumatoid arthritis, where you can see joint erosion. But in an early disease like this lady had only 6 months, you may not see erosions even in rheumatoid arthritis. So, in a patient who looks like rheumatoid arthritis, take a detailed history of system review. Is there any other system involved or not? And then you can think of a diagnosis of lupus. So this is a very common scenario in internal medicine OPDs. So this is a 15-year-old boy who had fever for 6 months. He had no localizing symptoms. And when we examined, we also didn't find much. He was only febrile. He had anemia. Everything else was normal. So he was actually a PUO who had no clues to us. So the chest X-ray showed that he had pericardial effusion. He had a previous chest X-ray which was normal, and the X-ray done at our hospital showed he had pericardial effusion. He had mild anemia. He also had leukopenia, and he also had lymphopenia. So when you have leukopenia, lymphopenia, and a person has got PUO, we think of 3 or 4 conditions. So HIV screen was negative, and TB is another one which can give you lymphopenia because of compartmentalization. His pericardial fluid was tested, which was AFB negative, it was exudative. And then we looked for features of lupus. He had actually no other feature except serositis, that is pericardial effusion. He had ANA positivity, very low complements, and he was also antiphospholipid antibodies in moderate titer. So fever is seen in about 50 to 70% of patients with lupus. And serositis is also not uncommon. Pericarditis is actually the most common of the serositis. So if you have fever with pericarditis, after you rule out common causes, think of lupus. The second is after pericarditis is pleuritis. Generally, pleural effusion is usually bilateral, and peritonitis is extremely rare. Okay, so let's see this lady's story now. She's a 26-year-old lady who came to us with
বাইক
abdominal.
এখন কিনে আনবি না আজ না পরে নিবি
Yes. Is there any question?
ওই একটা তো আমিই লাগাতে পারবো ওইটা তো আমি
Continue.
Okay,
Someone
so
is
this is a
talking.
26-year-old lady who had abdominal distension and fever for 2 months after a normal delivery. She had delivered her first child 2.5 months ago. After about 10 days of delivery, she noticed that her abdomen was getting distended. She was also having progressive breathlessness. She had mild pedal edema and mild oliguria. So obviously the obstetrician thought that she had a infection and she had low grade fever. But however, she had no history of any connective tissue disease symptoms. She had actually come to our emergency. And in the other hospital, she had already had a cytic tab done. There were 4 liters of fluid was tapped and it was reaccumulating. So she needed repeated ascitic tap. And the ascitic fluid showed only 250 cells, which are predominantly lymphocyte. Somebody had reported that the echo was showing thickened pericardium. So a possibility of constrictive pericarditis was also thought of. She had a mild elevation of her serum creatinine and her albumin was low. But she was just immediate postpartum period. Her TSH was also mildly elevated. So when we saw her, her JVP was normal. So a normal JVP almost excludes a diagnosis of constrictive pericarditis. She had massive ascites. She had bilateral pleural effusion. At this time, she did not. She had mild pitting pale edema. Besides this, there were no other findings. She had no hepatosplenomegaly, nothing in the skin, no CNS symptom. So we thought of these possibilities. 2 months postpartum, is it Budd-Chiari syndrome that we are not able to feel the liver because of massive ascites? That she had chronic liver disease which got decompensated postpartum. Constrictive pericarditis, at least we did not think because she had normal JVP. Cardiomyopathy also because she had normal JVP, very unusual. The other thing was polyserositis. And does she have infective peritonitis? But she has already been treated with enough antibiotics outside, and her ascitic fluid was not suggestive of infection. So we worked on these lines, and we found that she had fairly normal counts. Her platelets were normal. Urine showed only trace protein, no sediment. She still had elevated creatinine because they had done multiple taps, and she probably had hypovolemia related high creatinine or some other reason. She had low albumin. Rest of the tests were normal. Biochemistry. Echo done at our hospital was normal. We did a Doppler to rule out any Budd-Chiari syndrome, which was normal. And the ultrasound showed again massive ascites without any organomegaly. The chest X-ray had bilateral pleural effusion, left little bit more than the right. So we didn't know what we were dealing with. We had ruled out all the important causes which are seen postpartum for a ascites, massive ascites. We also did a repeat ascitic tap, and again it showed the same thing, that it was very few cells, mostly lymphocytes. So we thought that she's a young lady. She has only mainly ascites, which is rapidly filling. We still need to exclude lupus in her. And we found that she had ANA 4 plus fine speckle. She had high dsDNA. Her antibodies to smooth muscle antigen were negative. ENA was negative. Her cardiolipins were negative. But she had low complement levels. She had normal ESR and a mildly elevated CRP. So CRP in lupus can be elevated when you have serositis. And a 24-hour urine protein came out to be 1 gram. So thus we made a diagnosis of SLE with sterile peritonitis in her case. And we started her on prednisolone 1 milligram per kg and hydroxychloroquine. And with that, she started responding within a matter of 5 days. And over time, she became absolutely all right. Her creatinine became normal. And afterwards, she never had any nephritis. So serositis as initial feature, as I told you, can occur as a presenting manifestation in only about 5% of patients with lupus. And as I said earlier, pericarditis is more common than pleuritis, and peritonitis is extremely rare. So people have calculated that peritonitis risk over time in a patient with lupus is about 8 to 10%. So old time when people used to do autopsies, people have shown peritoneal inflammation in about 60% of the autopsies which were done. And it generally happens when the disease is active. And this is how it presents. It can present with abdominal pain, distension, and a clinically detectable ascites. Massive ascites is reported very, very rarely. So this patient was a very unusual patient who had recurrent massive ascites, and we could not find any other cause. And finally, we could make a diagnosis and treat her well. So we have discussed serositis and we have discussed arthritis in the setting of lupus. So let's see this lady. What does she have? She's a 31-year-old female who had rash for 4 months. It started from here, which was erythematous, then became black after being treated with antibacterials. And she had polyarthralgias for 3 months, but no swelling. She had oral ulcers for 3 months, which were present on both buccal mucosa and palate. She had tender nodules over index finger and thumb. Along with this ear lesions and malar rash, she also started having alopecia. She has fever, malaise, and fatigue. So if you see, most of her manifestations are localized to mucocutaneous area. She has basically skin and mucous membrane involvement predominantly. So this is another form of lupus which generally goes to the dermatologist but can come to you if it is not improving. She was treated outside with corticosteroid and hydroxychloroquine, and whenever a dose of corticosteroids were reduced to 10 milligrams, she used to have a recurrence of symptoms. And so somebody had added azathioprine. She had mild anemia, so that is why that dermatologist sent this patient to us that she is developing anemia. So I am not very comfortable giving her azathioprine. On examination, she had no symptoms suggestive of Sjogren's syndrome, CNS, any test, no symptoms. She had attained menarche at 12 years. She has never had menorrhagia. She has had 2 normal deliveries. So if you see her skin lesions, she has these are the characteristic ulcers which you see on the hard palate. So if you see hard palate ulcers like this, which are painless and which are very superficial, they are almost pathognomonic for lupus. You can see that she has diffuse alopecia as well as she has alopecia patches. Then she has these nodules on her hands. You can see they are present on the dorsum as well as on the side of her fingers. Except pallor, she had no other findings and the skin manifestations. So I'm just showing you other skin manifestations. So sometimes you can have rash like this, which is scaly, indurated, and all here, where lobule is not involved, only the cartilage is involved in lupus. This is also involved, and you can get rashes of multiple different types. So this is what I'm showing you. Sometimes it leaves a deep pigmentation at the end. So this is a discoid lupus which has left deep pigmentation. At this time, this lady has nothing, but it can sometimes be so angry looking. And rarely you can have vasculitis of the pinna. And the pinna may have been eaten up because of vascular infarcts. And this is the characteristic subacute cutaneous lupus rash, which looks like psoriasis, but it will be only in the sun exposed areas, generally above the waist. So the various skin manifestation which you can see in lupus, I've shown you malar rash. You can have diffuse erythema, the discoid lash which leaves hyperpigmentation or hypopigmentation, a subacute cutaneous lupus, oral and nasal ulcers as we saw in the first patient. You can also have erythema nodosum. You can get Raynaud's phenomena. You can have digital gangrene, and you can have both scarring and non-scarring alopecia. And skin is one of the most commonly involved organ seen in lupus. And it's a window. So if you can recognize the rash, you can always think of lupus. So patients who have skin manifestation actually get diagnosed early. But those are not the patients which we see. They are seen predominantly by dermatologists. So this is a story, long story of a patient who was 29 years old. In 2014, she had polyarthritis, urticarial vasculitis, and fever. She has been treated with multiple courses of steroid with clinical response, and she keeps on taking these courses every 3 to 4 months whenever she gets recurrence of symptoms. And this has been going on for 6 years. In July 2020, when she started having fatigue, she was found to be anemic and she required 5 units of packed RBCs. She also had one episode of hemoptysis. Somebody thought that she has TB because she's been receiving steroids. So she was given a course of anti-tubercular treatment. However, things didn't improve. And she came to us and she was in September 2020, she was developed severe anemia and pedal edema and her creatinine also increased. That is the time she got admitted to a hospital at her local place. But things were not going well, so that is why she was referred to SGPGI. With rapidly progressive renal failure, anuria, her creatinine had jumped up from 2.3 to 4.9, and she had few episodes of streaky hemoptysis. And when she came, she was dyspneic at rest. So she came to the emergency with this kind of a manifestation. So that is what we thought was that does she have hypocomplementing urticarial vasculitis because 6 years she's been having urticarial vasculitis, or she has a serious complication of lupus, that she has lupus with diffuse alveolar hemorrhage as well as renal disease, or she has ANCA-associated vasculitis, because vasculitis can also present with this kind of manifestation. But what you see here, she had anemia, she had thrombocytosis, which actually went against a diagnosis of lupus, which actually favored a diagnosis of vasculitis. She had high creatinine, she had high CRP, but her ANA was positive. She also had high dsDNA, she had low C3, she had normal C4, she had multiple other autoantibodies, anti-CCP, anti-PR3. So lupus is one disease where you can get multiple autoantibodies. But patients with ANCA vasculitis usually would not have ANA positivity. So that is why our impression of this patient was that because she had arterial vasculitis, she had fever, she now has rapidly progressive renal failure, so the possibility of lupus was strong. She had DCT, ICT negative. There was no evidence of hemolysis to account for her anemia. Anemia is probably because of that she was having hemoptysis. Her PCR for CMV and COVID-19 was also negative. Thus, what she had was SLE with pulmonary renal syndrome. And now you are seeing the chest X-ray that there are basal haziness. But the CT showed more. If you see her CT, there is patchy consolidation in both lung fields. So for diffuse alveolar hemorrhage, actually CT is a much better investigation than chest X-ray. Chest X-ray takes a long time to show you those patches. And these are predominantly located in the central areas. So she had pulmonary renal syndrome, and pulmonary renal syndrome can occur either because of pulmonary capillaritis, which gives rise to diffuse alveolar hemorrhage, and along with renal failure. Sometimes patients with lupus who have renal disease can develop pneumonias, and they can come to you like a pulmonary renal syndrome, and the infection can aggravate the renal failure. You can sometimes have myocarditis with acute pulmonary edema, and because of hyperperfusion, they can have increase in serum creatinine. Sometimes right-sided endocarditis can give you multiple consolidations in the lung and also renal failure. Obviously, disseminated intravascular coagulation secondary to any sepsis can give you both renal failure and pulmonary consolidation, and this one. And catastrophic antiphospholipid syndrome, which is a syndrome where you get thrombi in multiple organs. They can exactly present like this rapidly progressive renal failure with diffuse alveolar hemorrhage. So we should suspect diffuse alveolar hemorrhage when you have unexplained drop in hemoglobin. Like this lady had a hemoglobin drop to 8. Or you have hemoptysis, but hemoptysis occurs only in 50% of the patient. It does not occur in everybody. And along with that, if you find pulmonary infiltrates, that is the time you should think of diffuse alveolar hemorrhage. But even if the chest X-ray is normal, you should do a CT scan to exclude diffuse alveolar hemorrhage. So it's not a very common manifestation. It is seen in less than 5% of patients, about 1 to 2%. But some of these patients can have antiphospholipid antibodies. Most of them, if treated early, can survive. But if they need ICU setting, that is a poor prognostic factor. So the lung involvement in lupus can occur because it can involve any part of the lung. As I showed you, you can have serositis, which can give rise to bilateral perfusion. You can have acute pleuritis, which can present with chest pain, and it can also have pulmonary embolism because of antiphospholipid antibody association along with lupus. You can have pulmonary arterial hypertension, which can present with chest pain because of pulmonary arteritis. We showed you this case, which is diffuse alveolar hemorrhage. Patient 5% or less than them can also have interstitial lung disease. And a very rare manifestation is vanishing lung syndrome, where you will find that the chest X-ray will show you patient will have dyspnea on exertion, and the dyspnea will get worse, and the lung volumes will keep on reducing. Nobody knows what is the exact cause for this, but it is thought that it could be either because of diaphragmatic myopathy, which leads on to basal atelectasis, and it is highly responsive to immunosuppressive drugs. We have had 4 or 5 patients who have totally recovered after being treated with immunosuppressive treatment. So it is just that you have to recognize this disease. Now let's move to the other organ. This is a 24-year-old lady who in May 2020 had fever, polyarthritis, oral ulcer, photosensitivity. So there was not much difficulty in thinking of lupus. In September, after a few months, she started having facial puffiness, lower limb swelling, loss of appetite, and had an episode of seizure. At that time, she was found to be anemic, and a diagnosis of lupus was made. In October 20, when she came to us, she also had ANA positivity. She had dsDNA was normal, her ENA was negative. She had low C3, but her 24-hour urinary protein was 1.15 grams. So we went ahead with the kidney biopsy to know what type of lupus nephritis she has. And if you see here, the kidney biopsy shows you that she has both mesangial and endocapillary proliferation. There is some amount of crescent formation here, and you can see fibrinoid deposits in the capillary walls. She also has immunofluorescence, shows you a deposit of IgG, IgM, IgA. So she had a highly active lupus nephritis and she had no signs of chronicity. So this is what a lupus nephritis patient would present to you. Sometimes the renal disease can come like this. This was a 6-year-old girl who had purpura on the legs. She had vomiting followed by abdominal pain, and she had knee and ankle arthritis. Obviously, the pediatrician made a diagnosis of phenoxyl purpura, which is very common in children. She also urine showed microscopic hematuria, and everything improved over a period of 1 month. But she had recurrence of the same symptoms after a few weeks. When you have recurrent HSP, not that HSP cannot recur. HSP can recur in about 30% of patients. But we need to think. We did not think. When she came to us, the resident who saw, he again found that she had purpura over legs and buttocks. She had arthritis of knee and ankle. She had mild anemia. She had microscopic hematuria. She had mildly elevated creatinine. So that was worrisome. Even though in few patients with HSP can have severe renal disease with crescentic glomerulonephritis. So we did a skin biopsy, and the skin biopsy was sent by us as HSP. The pathologist called us up and said, "Oh, we are seeing a lot of IgG. There is IgA, but there is a lot of IgG. So please rule out lupus in her," because we had not thought of lupus in her at all at that time. And when we did her serology, she was ANA positive. She had very low complements. She had high dsDNA, and her kidney biopsy was done later, which also again showed diffuse proliferative glomerulonephritis. So lupus can, so in a patient who has recurrent HSP or HSP occurring in a young female, always do ANA and exclude lupus. So renal involvement in lupus can be either just that the patient does not have renal symptoms, but you have done the urine exam and it shows you asymptomatic urinary abnormalities like proteinuria, microscopic hematuria, or the patient can just present with nephrotic syndrome to a nephrologist. Or sometimes patients just directly present as chronic kidney disease to the nephrologist. And when they take the history, they find that the patient had had history of photosensitivity, some rash, some pleural effusion in the past, and then they make a diagnosis of lupus in there. And rarely, as I showed you, patient can present with rapidly progressive renal failure. And sometimes when you examine the patient and you find hypertension and there is no other cause for hypertension, and then you look at the things, you find that the patient has renal disease. So every patient with lupus at presentation must have serum creatinine, an estimated GFR, a urine analysis, protein creatinine ratio. Because lupus nephritis is one thing which occurs in nearly half of the patients at presentation, and it is one factor which determines the prognosis in lupus. So that is why we need to be very careful. And I'm not discussing most of management, but I'm just telling you that all patients with lupus nephritis should get supportive care, which you give to every patient in medicine. Like cardiovascular risk should be assessed. If they have proteinuria, give them renal protective medicines with ACE, angiotensin converting enzyme inhibitors. You avoid nephrotoxic drugs, prevent acute kidney injuries, give them prophylaxis so that they don't get infections. If you're going to treat them with steroid, give them calcium, vitamin D, avoid ultraviolet light exposure. So these are bare minimum things which an internist should always do, besides the rheumatologist giving immunosuppressive drugs. And all patients should receive hydroxychloroquine because that is shown to reduce the incidence of relapses. And the treatment of lupus nephritis, I'm not going into detail, but it involves basically steroids, basically IV methylprednisolone followed by low dose steroids and use of immunosuppressive agents. So we have looked at the kidneys now and the skin. Let's see the other organs. So this is a patient whom we are seeing for last 20 years. She came to us at the age of 15 years, and now she is 35. She had photosensitive malar rash off and on for 2 years prior to coming to us. And when she came to us, she had acute left hemiparesis. She was evaluated locally where the MRI had shown hyperintense areas in the C2 segment. So they had thought of multiple sclerosis, oblique tuberculosis, and treated her with high dose steroids and anti-tubercular treatment with which she had improved partially. So in the 2005, when she came to us, she had seizures for 1 year. After that episode, she was having seizures off and on, and seizure would occur 1 to 2 per month. It used to be associated, it was generalized tonic-clonic and was associated with urinary incontinence. And she has had a seizure just few days ago, maybe a few hours ago when she came to us. She also had this malar rash for last 1 month. But there was no history of oral ulcers, chest pain, palpitation, blurred visions, or any other system involvement. On examination, because she had received steroids for her with her ATT, she had Cushingoid faces, she had buffalo hum, she had these hyperpigmented macular lesions over the malar area, she had oral ulcers, she had diffuse alopecia. Her power in the left side was grade 3 in the shoulder, elbow, hip, and knees, and all other system examinations were normal. So she had this characteristic rash, which she had a photo of her. Showed us the photo, and you can see that this is the rash which spares the nasolabial fold. Very characteristic rash. Children, fair children, you can see rashes very nicely. And she had at that time when she had this rash, she also had erythema over the forehead. And now she has had this left hemiparesis and seizures. So what we found anemia, thrombocytopenia. So thrombocytopenia is another clue to lupus. She had all the serology for lupus. She was negative for anticardiolipin antibody, and her MRI showed that she had had a right temporoparietal infarct, which happened 1 year ago, and now she had only gliosis. And this gliosis was probably responsible for her recurrent seizures because she was not compliant to her anticonvulsant therapy. So this is the final diagnosis we made, that SLE with left-sided residual hemiparesis with scar epilepsy. So we put her on valproate, hydroxychloroquine, low-dose steroid, and methotrexate because she had a skin disease. So if you see her story, in 2010, she developed acute transverse myelitis. At this time, the MRI showed that she had a longitudinal myelitis going from C2 to T4. This time she was lupus anticoagulant positive, while her CSF examination was fairly normal. So we treated her with methylprednisolone and cyclophosphamide, along with the previous therapy of anticonvulsant. She completed cyclophosphamide 3 monthly. In that time, we gave her full dose because she is actually very poor. And maintenance treatment was given only with hydroxychloroquine. She did very well for few years, and then she was lost to follow her. From 2015 to 19, she didn't come back because obviously she was doing well. She said, I've been well for from 10 to 19, 9 years. She's had no problems. So obviously she didn't want to see us. But in 2019, she had another episode of myelitis. At that time, we gave her rituximab. Next 6 years. She has this classical Mara rash. She has all the serology for lupus. So lupus can also give you demyelination, which is almost like. Now we have tested her also. She is anti-aquaporin 4 positive. So this is our data of our 1950 patients which we have collected across India, and IPGMR is also a part of this disease, this cohort. So if you see neuropsychiatric manifest, headache is very common. Seizures are seen in about, out of these patients, 25% of patients had some neurological manifestation, and seizure is one of the most common manifestation. Patients can present with acute confusional state. Occasionally, patients can have psychosis. So demyelinating disease are not very common. We saw it only in 1% of patients have demyelinating disease. It can also involve the peripheral nervous system. Like we had 4 patients who presented like acute Guillain-Barré syndrome and mononeuropathy or cranial neuropathy. Or polyneuropathy is actually the most common out of the peripheral nervous system in manifestation, while among the central nervous system manifestation, seizure is the most common, followed by headache and psychosis. The most difficult problem in neuropsychiatric lupus is the attribution. How do you say this headache is because of lupus? Or how do you say this is because of lupus? So that is the most important thing, is to exclude all the causes. because neuropsychiatric lupus can occur independent of the rest of the clinical manifestation. Like this girl, if she didn't have the malar rash, it would have been very difficult to make a diagnosis of lupus in her because she has no other organ involved. Now let's move to other system. So this is a patient whom we have seen not very too far a year ago. He's a 27-year-old male who had bloody diarrhea and somebody had done an endoscopy and shown some ulcers. He had fever and he went into shock requiring inotropic support because he had such a massive GI bleed in September 2020. The investigation outside showed that his stool was positive for Clostridium difficile. They had done a colonoscopy which showed colitis. He was treated with antibiotics, mesalamine, and when he came to the emergency, he was on noradrenaline infusion because he was in shock. So he was admitted to our medical gastroenterology ward where they did a repeat colonoscopy and they made a diagnosis of inflammatory bowel disease, thinking more of Crohn's disease than ulcerative colitis. But what they found was that he had decreasing in urine output, rising creatinine. So they initially thought that all is because of shock. But when the urine examination was done repeatedly, it showed proteinuria and active urinary sediment. That is the time they called us. That can it be something else, some connective tissue disease? So when we went and saw, we saw this CT scan which shows mucosal thickening and increase in capillaries. So this looks like mesenteric vasculitis. So we ordered a lupus serology, which all came positive. So we treated him with methylprednisolone pulse, and obviously he required hemodialysis because his creatinine was very high. And then he was later shifted to our ward, where he developed left axillary deep vein thrombosis in the hospital because obviously he was dehydrated. He was on so many multiple drugs, lying in bed. And so we gave him cyclophosphamide after we given him methylprednisolone, and he totally recovered. So the GI bleed can also be the presenting manifestation in patient with lupus. So I'm telling you situation in every specialty of medicine. So think when you have two organ involved, like this person initially they didn't think that the urine exam was anything. They thought he's catheterized, so that's why he's having this proteinuria and some hematuria. But because multiple reports showed that, that is when the bell rang. So GI bleed in lupus can occur either because of thrombocytopenia or the drugs which we gave or steroid-induced GI ulcer, sometimes coagulopathy because of autoimmune hepatitis, or like in this patient, lupus enteritis. Even inflammatory bowel disease prevalence is higher in lupus. It can all they are prone to infections or rarely because of mesenteric thrombosis. So these patients need a detailed evaluation to figure out what is the cause for the GI bleed. So this is again our data from the INSPIRE cohort, which has 2,503 patients, and we found that 10% of patients had GI manifestation. And I showed you a case of ascites. The second most common manifestation is enteritis, which can present with abdominal pain, abdominal distension, GI bleed, and pancreatitis. So if a young female comes to you with pancreatitis and does not have gallstones, think of lupus. At least exclude lupus. Sometimes it can also present as acalculous cholecystitis. So, okay, so we have done the GI. Now we move to the hematology. So this is a 30-year-old lady who had polyarthritis for 3 years. She had ecchymosis, menorrhagia, and epistaxis for 6 months. So she was diagnosed as ITP and she was treated outside with prednisolone, danazol. There was no response, so she was switched to azathioprine. And this was in September 2024. In January, she was relabeled as SLE with ITP at the place where she was being treated. So because she wanted to conceive, so they didn't want to give her cyclophosphamide, they started her on tacrolimus. Because despite tacrolimus, she still had platelet count less than 10,000. So that is why she was referred to us in March 25. When we saw her, her hemoglobin was 12.9. She had normal total count, and probably this count was high because of she was taking steroids. She had platelet count of 10,000. The peripheral smear showed thrombocytopenia with large platelets. The bone marrow she carried from outside, which showed increased amount of megakaryocyte compatible with ITP. She had ANA 3 plus speckled. Her dsDNA was little high, but rest of the things were all normal. So we gave her rituximab and she went into complete remission. So thrombocytopenia is a very common manifestation in lupus. Its prevalence varies from 10 to 40%. Most of the time, it's generally around 80,000 to 1.2 lakhs, and it is less severe compared to ITP. The bleeding risk is more in pediatric lupus than in adult. In adults, there are patients who present with severe ITP, immune thrombocytopenia, but it's not common. And you can have multiple causes can lead to thrombocytopenia and lupus. If you have antibodies to the thrombopoietin, then they have a very poor prognosis because they don't make platelets at all. So there is a marrow failure. Mostly they have antibodies to the membrane antigens on the platelets, which is GP2B3A. So these patients respond beautifully to immunosuppressive therapy. And you can use, so these patients actually all the platelets get destroyed predominantly in the spleen. Old time we used to do splenectomy, but nowadays splenectomy is not needed. You can treat them with immunosuppressive therapy, and if they don't respond to the usual azathioprine, mycophenolate, you can try rituximab, which gives you a fair response in about 60% of patients. And this is what happens. So there are patients who will initially have only ITP. They don't have any symptoms of lupus. And about 3 to 10% of patients with lupus can develop, of ITP can develop lupus over 10 years. And when the lupus comes, it's generally an acute presentation. So these patients may have severe thrombocytopenia, they may develop some other manifestation like autoimmune hemolytic anemia along with it. And they can occasionally present with life-threatening hemorrhage like intracranial bleed or GI bleed. But they have excellent response to steroids. It's a chronic presentation, which is patient will continue to have platelet count hovering around 75 to 1 lakh. And occasionally in between it goes down. With viral infection, it goes down. They generally don't have any symptoms. They do not respond very well to corticosteroids. So you treat them if they have bleed. Otherwise, if they have platelet count above 50,000, you may not even treat them. Just give hydroxychloroquine. Sometimes the lupus can present to the neonatology. This was a baby who was born to a lupus mother. The mother was in complete remission. The baby had this kind of a annular rash. I hope you can see it, but not very clear. So there was an erythematous rash on exposure to light, and this became more obvious when the baby was given phototherapy. The baby also had mild thrombocytopenia and mild leukopenia with mild transaminitis, and this generally disappears on its own. Nothing needs to be done. So lupus, as I showed you now in the last 45 minutes, that lupus has a very varied clinical presentation. The three most common early features of lupus are fever, fatigue, and arthralgias. And this is the rash by which a diagnosis of lupus can be easily made. This is the characteristic rash which has total sparing of nasolabial folds. But these criteria do not represent what we see otherwise. Like you would not think of lupus in a patient who presents to you with fever, fatigue, and arthralgias. So more symptoms develop when the patient comes to you. So when to suspect lupus? You should think of lupus when a patient has unexplained fever. You've ruled out all common causes. When a patient comes to you with glomerulonephritis, especially if it's a female, you have unexplained multisystem disease. You're not able to tie up things like that boy with GI bleed thinking of IBD, but patient is having repeated urine exam showing proteinuria and active sediment. If you have serositis with arthritis, uh, agreed, pleural effusion can occur in rheumatoid arthritis, but think of lupus. If you have skin and joint disease occurring together, or you have unexplained neurological symptoms and signs, these are the situations when you should think of lupus. Not in everybody. In general medicine, common diseases always come first. Lupus is not a common disease, but it is a disease which should not be forgotten. There are many differential diagnoses of other connective tissue disease. I showed you vasculitis like hinox-Schönlein purpura like presentation can occur in lupus. You can have dermatomyositis where muscle disease and skin rash and the patient is lying in bed. People think it is arthritis and skin rash and refer to you as lupus. Infections. Bacterial endocarditis can have lots of features of lupus, can have splenomegaly, rash, fever, features urinary abnormalities, pulmonary infiltrates, septicemia, hematological malignancies, drug reactions. So when you think of lupus, do ANA. It has got a high sensitivity. It does not make a diagnosis of lupus, But if ANA comes negative, the probability of lupus is low. Think of some other diagnosis. Only 2% of patients of lupus are actually ANA negative. And retest if you have a very high clinical suspicion of lupus, or you do anti-Ro antibodies. Anti-Ro antibodies can sometimes be ANA negative. And once you've made thought of lupus, look at degree of organ involvement. Do complete blood count, Coombs test if there is anemia, urine exam in every patient, creatinine to look at renal function, a chest X-ray which may show you pleuritis, serositis, an ECG. If the patient has CNS manifestation, obviously CSF analysis and MRI scan. And disease activity we assess by anti-dsDNA antibodies and complement levels, but they can be normal. They are elevated only in 60%. And kidney biopsy if there is an indication. Patient has nephritis. Now let's see some other cases. So this girl is 10 years old. She is referred to us as lupus. She has fever, she has joint pains, she has anemia, she's febrile, her blood pressure is just 95th centile, she has multiple joint tenderness but no swelling, she has hepatosplenomegaly, she has small lymph nodes. So everything fits in very well with lupus. But what doesn't fit in? She had pancytopenia, that also can occur in lupus. But because she had tenderness out of proportion to her symptomatology, she also had actually bony tenderness, which was actually missed by a resident. So when we examined her, she had sternal tenderness. So always when you have this kind of a patient who comes to you with fever, joint pains, but not much of swelling, too much of pain, pancytopenia, always look for sternal tenderness. She had her marrow was packed with lymphoblasts. She actually had ALL. So ANA positivity does not make a diagnosis of lupus. It has to be read in clinical context. Okay, this is another, you'll see lots of such patients who will be referred to you as lupus. He had pain in different joints and muscles for 4 years, and no diagnosis has been made despite many consultations. And they were looking for some straw, and somebody did an ANA came positive, so they thought that the patient has lupus. So she was referred to us. She actually has history of constipation, poor sleep, anxiety. She has no features of lupus at all. And when we examined her tender point, she had 14 out of 18 tender points. So what does she have? She actually has fibromyalgia. But her ANA is positive. So 5% of general population can have ANA positivity. So just ANA positivity is not equal to lupus. And then this patient, she had seizures in the setting of lupus. Was diagnosed to have lupus. But when you have lupus, so hear her story. She's a 12-year-old girl who was diagnosed to have lupus in June 2022. She had fever, arthritis, and lupus nephritis. She received methylpred, cyclophosphamide, and prednisolone. And in a month later, she came back with seizure. It was very short duration, no recurrence. So when we examined her, what we found? She had hypertension. Actually, she was in the ward, she developed press. So she has these features where you see posterior reversible encephalopathy syndrome. So these patients, when you start them on methylprednisolone and steroid, they can develop headaches, seizures, encephalopathy, and hypertension. So don't think that this is part and parcel of lupus. Just control the hypertension, it will get best. So secondary causes also have to be thought of in patients with lupus. So see this lady's story, the last case probably I have. She came to us in 94, so almost 30 years. 16 years of age when she came to us. She had fever, polyarthritis, rash, lymphopenia. So we gave her only hydroxychloroquine, low dose prednisolone. After 5 years, she had thrombocytopenia. We gave her azathioprine. Then in 2003, at 25 years of age, she had renal flare. Her biopsy showed class 4 nephritis. She was treated with prednisolone and cyclophosphamide. And after third dose of IV cyclophosphamide, she had fever with chills. She came, the X-ray showed that she had circumscribed nodule with areas of breakdown in the chest, in the left upper zone. And she had also developed, oh sorry, this was a male. So he had developed steroid-induced diabetes. We treated with antibiotics and everything became all right. 4 weeks later, the patient comes with episode of generalized tonic-clonic seizures, 3 episodes. There was no finding. Patient was absolutely normal by the time he reached us. And neurological examination of the fundus was normal, so we thought maybe hypoglycemia. But when the MRI was done, it showed brain abscess. And when we re examined her, we found that there was a small 2 centimeter subcutaneous nodule on the left arm. And when that was aspirated, it actually has nocardia. So never forget infection in a patient with lupus. Don't think all this is happening because just because of lupus. We can easily say this seizure is because of lupus or it is because of hypoglycemia. Always look for other causes. So we have seen 4 or 5 patients. At that time, we had seen these 3 cases with lupus who had no cardiosis. So, in summary, ladies and gentlemen, suspect lupus when you have multisystem disease. Test for ANA when you think of lupus, but ANA positivity does not make lupus. ANA is only to exclude lupus. It's a highly sensitive test. If it comes negative, think of other diagnosis. And assess extent of involvement as organ involvement can be absolutely asymptomatic. Renal disease may be asymptomatic, serositis may be asymptomatic, cytopenias may be asymptomatic. Early diagnosis, effective treatment prevents damage and improves outcome. And never forget mimics, infections, malignancies, and fibromyalgia. Your eye sees what your mind knows. Okay, thank you. I have taken a significant period of time, but we can have questions.
No, no, that was fantastic. Now, Dr. Ganguly, please see the chat box.
I'm finding no question.
No questions. That's odd.
Okay,
What
one
does the
thing,
word lupus mean? Okay, somebody has asked, Mr. Maninder Pal has asked, what does the word lupus mean? The lupus is actually a word which has come from wolf. So
cool,
in
cool.
it's a Latin word. So because the malar rash in olden times, I have not shown you the horrible ones which we have seen. It looks so bad that as if part of your face has been eaten up. So it looks like a wolf. That is why the name lupus comes from there. So
And
please tell us about male lupus, how to suspect and at what age maximum it can be seen. So male lupus, actually if you see, the gender differences start appearing after puberty when the hormonal changes occur. If you will see kids at the age of 5 years, the female to male ratio is only about 3 is to 1. If you see at around 10 years or 9 to 11 years, the female to male ratio is about 7 is to 1. As you attain puberty, the female to male ratio becomes 9 is to 1. And that is what is sustained. If you see elderly onset lupus, it is again back to 3 is to 1. So, male lupus can occur at any age, but whatever we see, most of it is children or elderly. And male lupus actually has more renal manifestations. Male lupus has a poorer prognosis. Male lupus gets diagnosed little late because people don't think of this disease in males. So these are the major differences.
male with hypogonadism suffers more
Yes.
from lupus.
So what people have shown is in males, it basically depends on how much X chromosomes you have. It's a chromosome defect. So if you have Klinefelter, you have a higher risk of having lupus. Hypogonadism because you have more of estrogens. Less of testosterone is supposed to be protective.
Protected.
So they can have more risk of lupus.
Now, one thing, Amita,
Mhm.
hello, am I
Yes.
audible?
Yes, I can hear you.
Okay. About your case, that is SLE with polycerositis.
Yeah.
Acha, I think in this issue of JIRA, one case was described SLE with polycerositis, and they have generally CA 125 more. So
Yes.
your expert opinion about
Yeah,
CA
that is
1?
the case we have only sent. We have sent that case. So that is a Tejelma syndrome. It's a syndrome. What happens is this is seen young female. We have seen 3 patients of those. So they are young females who will have ascites, who will have pleural effusion, and they will have high CA 125. And
Yes.
some of them will be thought to have ovarian malignancy because sometimes the ovaries are follicular cyst is there. They will just keep on running around from one place to another. They will have multiple CTs, PET CT done, everything done. And when because once everything is excluded, that you don't have any, obviously when you have elevated CA 125, first possibility is malignancy. This is a rare syndrome,
Yeah, yeah.
and as soon as you give them steroids, the
If
ascites just vanishes away.
because in the
Yeah,
just 8 days ago, in
yeah,
one of our institution present such case, and
yeah.
I thought it may be like your case, which is also called pseudo-mix syndrome.
Yeah, pseudo-mix syndrome. It's like a pseudo-mix syndrome. So
Okay.
it comes by some name. I'm not
Okay.
very good at remembering
Second
names
thing,
of
okay,
syndromes.
second,
It's some
okay,
Tejelma
second,
syndrome, Tejelma syndrome, Tejelma syndrome, something like that.
second thing, I am telling from my experience
Mhm.
that if a patient comes from big joint polyarthritis like reactive arthritis and RA factor is negative and ESR is high, before stamping it as seronegative arthritis, I always perform one ANA,
Yes,
especially if CRP is less. Because
absolutely.
in my career, I found two cases where the patient present with something like reactive arthritis syndrome, like reactive arthritis.
Absolutely.
And the third point about your case of fibromyalgia with ANA positivity, it is very much important in which dilution it was positive.
It
If
was
in a case of
positive in 1 into
fibromyalgia,
400. That can also happen.
uh, if in a case of fibromyalgia, ANA is positive in 1 in 160 dilution, I think that case should be followed up for few years, that any day it may um, come with the full manifestations of SLE. Do you agree with me?
Yes, absolutely. So the other actually not with lupus, but they may come back with Sjogren's syndrome. Actually, Sjogren's more often presents with fibromyalgia, and
Mm.
the fibromyalgia associations are even stronger with Sjogren's. So we tell them that at present you do not have any features. If you develop any of these features, dry eyes, dry mouth, any rash, any other features of joint pains, anything, you come back to us. If you find any joint swelling, please come back. So we give them a list of manifestations and ask them that if they develop any of these, you come back. But a lot
Okay.
of them, their ANA becomes negative afterwards.
So
So
one thing
transient positivity can occur because this lady was going on for 4 years.
for you. So one thing is
Nothing
most
much.
important, especially for rheumatologists, that which dilution N is positive.
Yes, absolutely.
Now, other thing I want to express that one of my patient, I am seeing her for last 20 years, suddenly ANA become negative. And I first give all the blame to the laboratory and send him to a renowned laboratory of our city, and still it is negative. Then in an a journal such as the North American Journal of Rheumatology, I found that in a Stockholm study, out of say 100 case, they found 13 patients which becomes in some of our life ANA negative. And they focus that RO52 is the most stable antibody in SLE than ANA, which becomes never negative in a carrier of SLE patient. Now, your expert opinion about this.
Yes, I said that there are 2% of patients who can be ANA negative, and ANA negativity can occur afterwards. And nowadays you see more often because of B cell depletion therapy. When you give rituximab, the patients can become negative. And as you said clearly that, as I showed also that if you have a high clinical suspicion of lupus, then one you retest. There could be pre-analytical error, sample may have got mixed up in the lab or something. You always retest. Second, you do an anti-Ro antibody because anti-Ro antibody can be negative on ANA, usual ANA screening. And as what you are absolutely right, that anti-Ro antibodies persist all throughout. And that is why you see so many babies are born with complete heart block with normal mothers. So it's a very common antibody. Once it develops, it doesn't go away. So it is a very common thing in general population also, anti-Ro antibodies. They have no symptoms. 90% of mothers have no symptoms of babies who are born with complete heart block because of anti-Ro antibodies. You are absolutely right. So there is
Thank
one
you.
more question by somebody, that how common is lupus presenting in perimenopausal patients? Does it have any special features? The lupus actually, what we say, occurs during the reproductive age group, but no age is bar. You can see individuals at the age of 70 years also, and you can see a child at the age of 1 year. So all ages it can happen, but it is most commonly seen in the reproductive age group. And lupus, which occur elderly onset lupus or whatever you call it, their features of dry eyes, dry mouth are more often seen. They are generally ANA negative. They may have more of arthritis. They have little less of renal manifestation. So these are all relative things. But in an individual patient, anything can come at any time.
Thank you. Now, over to Professor Arun Sarkar.
Okay. Thank you, Amita, and rest of the now the vote of thanks will be given by Professor P. Sarkar, Partho Sarkar. Partho?
Hello.
Oh,
Okay. A huge congratulations, Amita. Actually, it is an absolute pleasure on behalf of West Bengal API and ICP to have a person like you, authority in SLE, in this master class that is masterly described. I think it is a very much kaleidoscopic view on all systems that you have described, and rightly spoken that time that somebody asked what is lupus. So one caption is there. It is a wolf in sheep's skin. So
yeah.
that is very much described over here. So my huge thanks to you, and I hope we will all meet in Shantiniketan also. And
Yes.
before concluding this, I must do the duty of giving the thanks to other fellows who have made this happen. So I must thank all the members of the coordinating body, that is Professor M.K. Rai, Dr. H.S. Pathak, Dr. Dipanjan Bandyopadhyay, and our secretary also, Dr. P.S. Karmokar, our chairperson, Professor R.N. Sarkar, and the chairperson of this session, Dr. S.B. Ganguly, have masterly conducted his duty as chairperson. A lot of questions and some problems that was also answered by you, and very important things that in each and every case you have put some learning points on behalf of us. So that is also very important. So thanks to all the audiences for putting their questions and be part of this program to have their knowledge enriched. So thank you everybody on all spheres, students, PGDs, everybody, and mostly our speaker, Amita, and Professor S.B. Ganguly. Thank you very much. I conclude vote of thanks. Now over to Professor Arvind Sarkar.
Thank you. I must
Yeah.
thank the West Bengal API and everybody else for inviting me. I always
Yeah.
enjoy teaching. And I always say
Yeah.
that where I did mistake, I learn from that. So it's good to keep
That
learning.
is true.
Enjoy learning and happy weekend to you.
Very true. Very. Thank you. Okay. Now we conclude this session and we'll meet in another after thing. I think after the Daseras next
Yeah.
class. And Amita will meet in Santiniketan.
Shantiniketan. Yes,
Okay.
we'll see you there.
Okay.
Okay, bye.
Okay.
Thank
Goodbye.
you,
Bye. Bye.
Amita. We will meet at
Okay, bye, Dr.
Central.
Ganguly. Yeah.
Same combination. I am chairman and you are speaker. Thank you.
Okay, that talk is very different. That is pure immunology.